So what we thought would be nice as a team, what we thought would be, is to do a sort of a baseline, right? So everybody talks about medication adherence. What is it? How is it? So please allow me just a few minutes to share with you some facts about medication adherence, how much its cost is, and then we'll ask our panelists to introduce themselves, introduce their backgrounds, and talk about their particular solutions, all right? So the first thing is, you see this photo here, right? Imagine a person who's 75 years old in rural America. I won't name the state because every time I've done that, I've hurt someone's feeling, right? So imagine whatever state that you feel that things happen. That person is on Medicare, has 4 or 5 chronic disease conditions, takes how many meds generally? 10. 15, 14, okay? Right? And try to imagine this person trying to get all these bottles right and taking in the morning, in the afternoon, in the evening, and you can see how deep the problem is, right? So the word non-adherence, one way to look at it is right meds, right time, right mix, very important. Take lots of meds, one physician doesn't know from the other which is right, which is not, and they're not talking to each other. So it gets even more confusing. And then generally the definition of adherence is that if they take medication 80% of the time correctly, they're adherent, okay? And there are many reasons why patients are non-adherent, right? Afford, copay, transportation, can they organize the meds, can they remember, travel, refills, and just goes on and on and on, right? And so people who've been in the trenches know that the last mile to the home is probably the most difficult, okay? And then the question is, how do we know a patient has been adherent? So normally we call, hey, are you been adherent? Are you taking your meds? And what do they say?
Yes.
Yes. And studies have consistently shown that this person here is extremely optimistic about their adherence level, right? Even when they're giving blister packs of 30 days and they're punching it out, right? And they miss, they still think they've taken most of them, right? So the way you measure is PDC, proportional days covered. You see how many refills they've done, how much is remaining, and there are many other measures. You can also look at the weight, blood pressure. If they come to the hospitalization often, you know that there's something wrong with somewhere, and generally turns out to be medication. So that's what is non-adherence. Second, actually, sorry, I got it wrong. So who is non-adherent, right? And then again, you can look at it from an investor point of view or an entrepreneur point of view. This is one way to look at what is the market size of this. How big is this problem, right? So first of all, 72 million adults take 5 or more meds, and some people here are probably in that domain. And 60% of them take incorrectly. I should tell you, personally, I will not name the med, but I do take one med, and I am about 70% adherent. And I spent 6 years and tens of millions of dollars developing technology to keep patients adherent.
Which means if he says 70, it's really like 60.
Okay. 40% of elderly hospital admissions are due to medication related, and 60% of nursing home. And then let's say now we break it down to disease level. Hey, are there any specific diseases that are a lot more? Well, how many people have heard of readmissions and the very high readmissions rates and so on, congestive heart failure? Okay, for people that haven't, I was going to say patients that haven't, for people that haven't, it turns out that 24% of the patients that are discharged. So think about this. Congestive heart failure patient shows up to hospital, whatever they do, procedure, and charge tons of money. Patient goes home. Within 30 days, 24% of those patients come back for rework, okay? And everybody's making money in the process, obviously, but now they're trying to figure out, okay, we got to cut down on this, and so how do you prevent readmission? It turns out that medication adherence is one of the root causes of high readmissions. Mental illness, people who are schizophrenia, schizophrenic, they're 40% non-adherent. Diabetics, 30% get hospitalized with low adherence, 13% with high non-adherence. With high adherence. So I'm sorry, what I meant to say is that if you're a diabetic and you are low in your adherence, 30% for that year, you have a chance of getting admitted to the hospital. All right? So, and even within different groups, Latino, African Americans, non-adherence is at a 40% rate, right? So it's a very, very deep problem, and it doesn't take genius to figure out that even if you can make $5 per patient, a non-adherent patient, you can have $1 billion company. So that's why a lot of us are chasing after this dream. Make sense? Okay. And I should tell you, nobody solved it. Okay. The question is, how much does it really cost? And I'm just going to focus on one number, and then I'm not going to go deeper because this is late in the day and nobody wants to see lots of numbers. So very simple. If you look at, this is a band of patients in different bands at different risk levels. So these are most of us here in the green band. These are patients at risk. This is patients with multiple chronic diseases. 7% of the population would have that, and the cost to manage those is $1,100 per patient, per member per month. If you go into a higher band, it's almost $4,500 per member per month. So the question is, are the insurance companies willing to pay $10, $15, $50, $100 to solve the problem? And they still get 10 to 1, 50 to 1 return on their investment, right? Insurance company. So keep that in mind. But as we talk later and as other people share their stories of working with insurance companies. And this is my last slide on the sort of the problem, right? I think it's the last slide. So we have access to actual data from insurance companies, okay? And it is very easy for us to see. So we have medical claims, so we have pharmacy claims, and we put all that together. And it's so easy to see that patients who are adherent to their medication cost far less. And let me tell you what is far less. You see what we're trying to do here, right? So we took patients, so we said, forget about the whole population. Let's just look at one insurance company that has maybe 1 million, 2 million members, but let's focus on Medicare patients with 3 or plus chronic diseases. You see what we're doing, right? I'm narrowing the problem down. I'm not saying medication adherence for everybody. So within that 100,000 Medicare members, 17.2% had 3 or more chronic diseases. Of that, 65% were non-adherent. So 11,000 members, almost 10% of all Medicare patients out there are non-adherent. You guys see the math? Okay? Medicaid patients, 2.4% of all people on Medicaid are non-adherent, and commercial population, so these are much younger population, so on, about far lower, about 2.2% are in this 3 or more chronic diseases, but still, look at the cost. $10,000 more to treat a non-adherent patient, $3,000 more to treat a non-adherent patient here, and $4,000 to treat a non-adherent patient, okay? So you can see the cost of non-adherent, and this is real data. It's not some analysis that someone did some research like Yuri did at Harvard or something, no. Okay? It's real, tangible stuff, okay, that we can back with actual medical data, right? Sorry, Yuri, just trying to. Okay. All right, guys. So what I like to do is I like to invite Vipul. Pegasystems, we're in his domain, so we have to be nice to him, right? And Vipul, if you could please share just a little bit about yourself, and then share with us Yuri.
Thank you, Yogendra. So I'm an industry principal in healthcare with Pegasystems. We have a set of solutions for healthcare, which I'm not going to talk about right now, and misuse my sponsorship position with you guys.
You can see him afterwards.
I definitely take you out for dinner. You're going to give a very good presentation on defining medication adherence and defining the problem, right? But ultimately, the key issue is this problem has only one solution. You need to engage with the patient. There's no other solution to this problem, right? So what are we here? And I would like to share this with you as a product community, because at Pega, we're really interested in addressing this challenge. We realize we can't do it alone. This is what we're hearing from the market. The market wants personalized customer service. They want personalized customer service across all channels. They want self-service. And more importantly, CIOs are coming to the realization that they need to provide an accurate and easily accessible picture about the member to the member, right? And members, it needs to provide appropriate decision points to them. It needs to empower the patient. You need to engage the patient. You need to, provide the member the information to take the decisions, etc. And most importantly, the last one is it has to be a two-way learning process. Not only does the member learn from our systems, but the health plan also learns from the members. It is a two-way learning stream. And that is the key in solving the medication adherence problem. Because with each new member we reach out to, not only does the member learn from the information we give it, but we learn from the member as well, right? Medication adherence is a great example. It is a classic example of a two-way learning problem, and it has, I'm not going to belabor this, it will have tremendous impact on our cost and outcomes. That's what the market is looking for. So I'm just going to step through some slides. This is a typical incoming call, inbound call. The context of the call could be anything. The guy could be complaining about his claims. The person may be asking for pre-auth for a procedure. It could be anything. But the moment he comes in, you should use this as a teachable opportunity and have the data in front of you and say, hey, I've been checking, I'm sorry you had a problem with the claim. I'm going to follow it up and make sure your claim problem is addressed. But hey, would you like to, based on your lab results, would you like me to, help you here a little bit, we can put forward an assessment. And this assessment doesn't have to be question and answers. It should be multimodal. Sometimes it's easier for a person to look at a picture and say, point to something. So, and we should be able to leverage industry best knowledge, to the problem. So these are some screenshots, and I'm definitely not trying to sell any of this to you. But what are the key questions around? Let's boil it down to medication adherence. What are the key problems we are hearing from our clients? And these are the questions we need the answers to. Can you help us identify high-risk non-adherent patients, right? Can you help us identify the attitudinal differences across age groups? Maybe the older people are less adherent than the younger people. Can you help us identify the chronic conditions and their impact on medication adherence? Can you predict for us what is likely to trigger non-adherence in a particular individual? Can you stratify based on impact? And more importantly, claims data by the time you get it is 3 months old. Can we leverage these mobile apps and adapt these predictions as we learn more and more about the individual? And then trigger proactive outreach, at the most probable stage of non-adherence. So I think we would like to share these problems with you because the whole industry is grappling with it. And I think what I would like to submit is that the 2 key points. One, it is all about patient empowerment and engagement. And number 2, we should be able to be ahead of the patient and be able to predict things even before the patient himself reaches that point, right? That's it. So I'll, I guess, hand over to the panel now. And if anyone wants to buy any Pega products.
If anyone wants to go pick up some food, you could do that while we talk.
Vipul, thank you. Thank you so much. So I do want to let people know that we will have plenty of time for Q&A afterwards. So make sure you jot your questions down, or please remember that. Now what I'd like to do is share with you, introduce you to the next panelist. His name is Yogendra Jain. Yogendra, please come over here. I was really trying to be very objective about this, and I will do my best. And I do want to let the panelists know that there's no way we can talk about adherence solutions that we've worked on for so many years without talking about the product. So it is okay to talk about your products, really. There's always a dilemma when you present, can you share? So what I like to do is share with you the product that I've spent many years working on. And we're talking about the solution. So I already shared the problem with you, right? So I'd like to share with you our approach to a solution, okay? So our approach to solution, and I'll just share with you anyways, I was going to share my background, but that's okay. First, let me talk about this, and then you'll know. Was to get a device in the home that'll keep the patient adherent, because we've realized that you have to get right to the patient and get them to take the medication. So this is what we call a pill station. It goes into the home. When it's time for the patient to take their medication, it chimes, right?
Please take your medication with food or water.
It'll give specific instructions about the set of medications. It'll also can do wellness reminders, and it'll tell you to record your blood weight, and also
your prescriptions are ready for pickup at your neighborhood pharmacy. Your pharmacy is open until 9 p.m.
So you can imagine when we did this demo with CVS versus Walgreens, right? We couldn't say the name, and so we had to genericize that. So now what happens when it chimes, a patient would open this, and it's a pill tray inside. And so you can see the first thing is they would see actual, you see the blue light? And what is the reason for the blue light? Morning, afternoon, evening, because many of our patients cannot remember which ones to take. Second thing is, a lot of them travel, so they should be able to take this, put it in their pocket, we should be able to detect that, and send them reminders on their phones. We need to make sure that it's open, easily openable. So a lot of innovation has gone into it, but what's really unique, one of the unique things about this, is that we embed a camera inside here, okay? So now you can imagine what the camera sees, right? And what the camera sees is something like this. So we get to see every single med that the patient has filled in here, if they've taken the meds at the right time or not, and if not, we call them in a matter of minutes. Right? So two things. Make sure the right meds are there, make sure they're taking them on time. Right? Then the other thing that we can also do is we have a feature called the call. There's a call button here. And you can imagine what this is for, right? If they have a question, they press this. I have a background in telecom, voice over IP, and other things. And so I said, would it be cool if every time they press this, this would become a speakerphone? Perfect, right? So now the patient is like fumbling through their meds or something, they press the call button, our advisors answer instantly. Well, it turns out, as brilliant as I am, that feature was extremely popular. So much so popular that patients just kept pressing that many times a day. And so we had to de-feature it. And so you get the idea, right? That you may think that high touch is really good, but there's a limit to it and how you want to do it. Anyways, so we have a whole backend that looks at it, and now we're able to get the data of the patient, of how adherent they are to each of the meds, how many calls has to be made to get to the adherence, and the cost to keep them adherent. We can also send a personalized text message here to them. We can also have their granddaughter record a message, and you saw that earlier voice came in. We can have the granddaughter's voice come through, saying, "Thank you, grandfather, for taking the meds." Okay? It turns out that some of these features are so interesting and so bonding that when we have tried to remove the pill station from our patient's home, there are tears in the patient's eyes and the caregiver, and our advisors come running to me saying, "Yogendra, the patient is crying, what do we do? They won't let us take the pill station home." Right? Those are the good things. There are some cases where some seniors say, "You know what? I don't need this, but my other friend over there needs it." Right? So there's both sides of the coin, right? You can imagine. So this is one possible solution, but as you well know, there are probably 50 other solutions out there for medication adherence. You have the simple organizers, you have dispensers, you have blister packs, so there's a whole array of solutions out there, and I do not want to make this a survey. I do want our other speakers to how much time? Okay, oh yeah, that was quick thinking. Okay. So when we ask our patients, "Hey, what do you think about the pill station?" You know, Marge, who's up there, loves the pill station. You know why? Not only she remembers to take the meds, but she can now remember to feed her dog Chester. And guess what? That allows her to keep the dog and stay at home, right? So we have to not only look at meds, but a lot of other surrounding issues that are med related. And there's a whole ROI as well. So for example, I'm not going to go through the numbers again. Let's do a very simple analysis of 100 patients that get discharged. Remember that readmission problem I was talking about? Right? So 100 patients get discharged, 27% of them generally come back. Let's say we only keep 9 out of 100 patients out of the hospital in those first 30 days. We can give about a 10x return on investment to the insurance companies. All right? So I've calculated all the cost of this, the cost of increase in medication because now they're a little bit more adherent, everything included, they still get a 10x ROI. Right? And we actually are willing to take the risk with our customers. If we don't keep the patient adherent, don't pay us. Right? So that's the kind of models, business models that we've been looking at. Let me actually skip this because my time is up. And you may also know that now there are incentives for hospitals and insurance companies to keep the patient adherent through the measures called STAR measures. And then if one does that, there's quite a bit of bonus that they get as part of it. So now the government incentives are coming in, the technology is coming together, and still a lot of us, I believe, are struggling to sign on our customers. And we can talk about that later, right? So with that, we'll hold the questions up to later. Thank you very much. Okay?
I am. There we are.
Okay. I'd like to introduce Carol McCall, please.
All right. How you doing, everybody?
Great.
Stand up and stretch. This thing is really cool. I thought it was actually a little like Bose stereo when I first stepped up.
It does play music quite nicely. I make sure the speakers are very high fidelity.
So it's a
No,
stereo.
it does play.
It's it's all these things. It slices and dices. Yeah. So I'm going to go back one. All right. And I've been asked to say just a little bit about, so who is GNS? And it was brought up that we actually work in the same building. But, and as it turns out, we work on, kind of related things. GNS is a company that's been around for about 15 years. And we do big data analytics. So we're one of those guys. And yet what originally for the company was a lot of deep computational biology. There really are kind of scary smart people over there. And that's with a hyphen, not a comma. Just doing really, really cool things with data and a lot of kind of first-in-class computational capabilities. That's been the case for 15 years. What's new is how they're being applied. And so what started out as a history in working with biologists, pharmaceutical companies, is now emerging in a post-reform world of working with hospital systems, integrated delivery networks, and health plans. And what we're doing now is we're really trying to accelerate the ability to offer intelligent interventions. And so if you think for a moment about reform, all right, reform is creating some of the biggest changes in healthcare, not just since Medicare, but ever. And it is driving sweeping changes and a lot of innovations. And what it's also demanding are new competencies. And one of these competencies is actually population health management. Is there anybody who hasn't heard the term population health management? Okay. So people are pretty familiar with what it is. But what it's becoming is table stakes. In order for health plans and the emerging class of ACOs to survive, they're going to have to pursue population health management. And they're going to have to get really, really good at it. And what it means is that they're going to have to be able to offer a sweep of interventions, and not just a one-size-fits-all. So as we heard earlier, there may be 50 or more different solutions to improve medication adherence, and different ones are going to be appropriate for different people. All right, and so what you need to be able to do, and what we help people do, is we help people maximize the ROI, the return on intervention, as they try to navigate that complex decision space. And we do that by doing a number of things. The first thing that we do, the math that you had showed earlier, we actually predict all of that in advance. And so what we'll do is we'll actually predict who's at risk for an adverse event, and where, if I change their adherence, can I reduce that risk, right? And then when I combine that with what it costs to run the interventions, and what it costs to actually purchase the additional medications, each and every person comes out with an individualized potential impact of these interventions. And so what we do is we personalize all of these analytics. And it allows us for each person to find the best match of intervention to person that maximizes that potential impact. All right, and what that allows our clients to do is to optimize their outreach and engagement. Because what's happening out there and what we hear is that everybody's trying to contact every member for everything, and what they're saying is, knock it off. One more phone call, and I'm going to unplug this phone. And so if you really want to engage me, if you really want to help me, then what you really have to do is to know me. And that means knowing those few things that are the most important for us to talk about right now. All right? And when people do that, that's what we call meaningful adherence. All right? And so how we go about that to maximize this intervention, when we talk with the health plan, there's really three things that they want to do. One is plan the interventions, right? So we take in all the data and try to figure out that best match. They need to implement them, so it needs to integrate with a workflow in a seamless way that actually helps people integrate. And then last but not least, they actually have to figure out which of these things are working, because I know yours works great, but not all of them will, right? Some things just won't work. And you need to learn as fast as you can which ones are people engaging on, where is adherence changing, and then ultimately where am I getting that event reduction that I want so desperately. And all of that is something that you want to happen in an accelerated fashion. And that's what we do. And the reason that we can do it, and what we believe anyway, that we do differently, is that we connect adherence to outcomes. And we do it because of the legacy of the company and analytics on causal inference modeling. So we identify where poor adherence is causing the adverse event, and we're changing it. Increasing that adherence can reduce that risk. We do analytics to find the match. As people engage, we do analytics to show who's engaging and who's not, and where are those meaningful differences, right? And then we actually maximize that by continuously analyzing all of this. So, what does all this translate into? I want to talk a little bit about value-based selection and value-based analytics. Because it was talked about earlier about the STARS program. CMS has these STARS. And the good news is that everybody's awareness of the importance of adherence is increasing. The bad news about STARS is that it's a very blunt instrument. And it basically says below 80% is bad. If I can get you to 80 or better, that's good. And what they're not recognizing actually is that a lot of the value in terms of reducing events comes beyond 80%. Okay, and that's what we're seeing. So when we compare these two, value-based versus rule-based, I want you to imagine that you are the CEO of a health plan or a health system. You have 1 million people for whom you're responsible. And when we look at, in this case, cardiovascular, diabetes, and respiratory, there's going to be about 100,000, a little bit more people that take those drugs of interest, all right? Now, if you were to go after that population, in a rules-based world, you'd find everybody to the left of that line, all right? And that'd be about 41,000 of those people that you would reach out and try to target. If you went after a value-based world that kind of did this individualized math, you'd target about the same number of people, but they'd be different ones, right? And that's the point, is that if you're trying to maximize the impact that you can have on the health of a population, one person at a time, you will make different choices where you have insights into where your actions have meaningful differences. And that's what we help people do. How that translates ultimately impacts the bottom line. Now, this is the economics, but it also allows you, when you have a positive return, to take those returns and invest in other things. This is what allows you to live to fight another day. And so here you can see how the math works out. About the same number of people, different numbers and different dollars, therefore, in terms of eliminated events, because, again, you're targeting people based on your ability for that change in adherence to reduce those. You're also optimizing your spend on the additional medications, and you're ultimately optimizing, there's a line you can't see there, which is how much did these things really cost, or the whole portfolio of things that I've done. And so ultimately you have a better net impact, all right? Now there are examples of these, I'm not gonna dwell on them. Here's Lucy. She'd get picked in a rules-based world and a value-based world, right? We showed that improving Lucy's adherence 25% would have reduced her expected cost by 14 grand on mid. Here's Nora. Rules-based would go after her. Value-based would not. You could increase her adherence even 45%, and you would only reduce her expected cost by $200. She may need a different solution. And here's my favorite, Ethel. Rules-based world would ignore Ethel, all right? Say, oh, she's above 80, she's fine. I say no. I know that improving your adherence 10% would have reduced her expected cost by over $10,000. And that's worth knowing, because Ethel's worth it, you can't keep. So, bottom line, with these three people, and these are real people, names and pictures have been changed to protect the innocent and guilty or whatever, or just me from wearing one. Adherence alone doesn't reveal the potential impact that you can have on somebody's life or the impact that you can have on the health economic situations. And so ultimately that's what we do, and that's why we call it meaningful adherence. We help people plan their interventions by simulating across a portfolio of different opportunities. We help them implement once they have identified and made that match made in heaven by integrating with workflow. And the most important thing is that over time, through continuous monitoring, tracking, and analytics, we learn which of these interventions is actually changing adherence and having the impact that people want. So that's what we do.
So now I'd like to ask Dr. Kevin Beth, please.
Hello. A little bit about me. I trained here at Beth Deaconess, stayed in the system, was an academic doctor, and became chief medical officer in the system at one of the community hospitals, BID in Needham. And I think one of my observations is we were going through patients who readmitted and patients who utilized a lot, was that there was a huge percentage of patients who had problems with medication management. And yet there was really no stored for medication management. There were a lot of clinicians, doctors, nurse practitioners, who were dumping into a black box, and no one was pulling out. So your PCP puts medications in, your specialist, you go to the emergency department, they add some more medications, you get admitted and the hospitalist who's never seen you before adds more, maybe they put you on a omeprazole during the hospital stay, which is appropriate, and inappropriate once you leave, but you stay on it. And next thing you know, you're on an average of 14 medications. So I noticed that and wanted to do something about that, and joined a company called Dovetail Health. We've been around since 2005, and if this is feeling to me kind of like a high-tech solution to the adherence problem, we are a high-touch, low-tech solution to the adherence problem. So maybe just the counter opinion. I think one of the things that you assume when you have a box like this, a pill station, is that you understand why the patient is not adherent to their medications. This assumes a certain amount of disorganization, maybe forgetfulness, lack of motivation that can be remedied by a grandchild encouraging grandpa to take the medications. We actually find that it oftentimes when we're in the home with patients, more commonly we find that it's health literacy, behavioral health issues like depression. It is really not understanding why they're even on the medications or agreeing that they even should be on that medication. And so things that are kind of more difficult and not easily remedied with a single bullet. So the type of stuff that we do, and I'll just make it real simple, is we through this risk stratification process that Carol was talking about, can identify the patients who are at most risk, the highest risk, the ones who drive over 50% of healthcare dollars. And for them, we provide a high-touch intervention, which is to put a pharmacist in the home or a nurse, depending upon the situation. And our focus is very special, which is to look at the medication regimen and really pick it apart. We do something called medication reconciliation, see what medications the patient's actually taking, if they should be on it. We try to identify barriers to adherence, and I mentioned some of them. We do safety screening optimization, synchrony, something as simple as trying to get the medication sourced one time a month and not 4 times a month. And then we do comprehensive medication review. It's a very high-touch technique through building relationships with patients, often in their home. We also offer moderate touch techniques, which are predominantly telephonic. So I'll try to focus a little bit more on the proprietary software that we use to try to identify patients. And it all starts with us with program design and configuration. I was down in Florida this morning talking to a healthcare system about doing medication management within their system, and it would start by going there and having an implementation process where we understand what they're doing, where they're doing it, and how we can forgive the use of the word dovetail into their solution. I usually don't do that, but I think I'm tired.
It's okay.
I'm tired. I'm not hungry, which is good because it would be worse if I were. But anyway, you have to do a lot of data processing to really understand who these patients are and who you should intervene on. One of the things that I would put out there is, for you who is trying to figure out the IT part of this, it seems to be, if you could somehow put in patient activation, that'd be a big deal. And what I mean by that is that there are patients who can be very complex on paper, but they're really into their healthcare, and they're very activated. Or they have a son or a daughter or someone else who makes them very activated. Those people don't need a lot of high touch. They're already on board. So anyway, we go through a process of intaking the patients, enrolling them. We tend to do quite well with enrollment. We depend on the patient population. For example, the employee population is much more difficult than the Medicare population. In the former, we have an enrollment rate in the 40 to 45%, sometimes 50% range, and in the latter, more like 60%, 65%. So we go through a process then of enrolling those patients, assessing them, going into the home, managing them, and then we are able to generate reports. What I'm showing you here is what we call the medication management module. In our proprietary IT software, we have a process whereby the pharmacists and nurses follow a standardized process so that we can be sure that our interventions are the same, whether they be in Florida, Massachusetts, Arizona, New York, Texas. And what that also does is allows us to really drill down onto medication management, what's happening with those particular patients. And what we're driving towards is something that we think is kind of important. Someone has already mentioned the last mile of data. I mean, there's big data, But then what's happening in the home is actually kind of the near patient, true north, gold standard of data. And that's what we're able to drive towards and reflect back to our partners. When we do that, we're able to generate this type of a report. This is a real report that goes to a clinician. And by the way, the patient in the home gets a report that's printed out there in the home at 8th grade level of English. And then there's a different report that gets sent to the clinicians, the care managers, the physician, which is more clinical. What you see here, let's see if this comes out, is that the first issue is one of adherence, the second is one of safety, and the third is one of cost effectiveness. I won't take you through what they are, because I don't get the sense that there are a lot of clinicians in the room. It would just be a waste of time. But, or maybe a waste of time, but I think the overall point is that we're really looking to make sure that the patient has the right regimen, that they're not on too many medications, that we exclude polyprescribers, that we're thinking about adherence, the safety profile, and of course, cost effectiveness matters quite a bit. When we generate this type of report, we're also meeting CMS MTM requirements. And so I'm not sure if there's anyone from a health plan in here which only resonates with them. But we're able to, careful here. Lastly, and where's Andrea, since I told you guys I did that in like 5 minutes. But only because I just want to give you a flavor of what we do and then leave it maybe for some questions if you'd like. What we try to do in the end is, as we're in the home, we're on the phone with patients, we're trying to generate what we refer to as near patient data so that we can really come up with actionable analytics in real time. Things that we can act on, trends that we can identify across maybe a health system, and issues that we can identify with specific patients. And in doing that, we're hoping that we're changing behavior of the prescribers and of the patients, so on both ends. When we do our job exceptionally well, we build a relationship with the patients, but that would be inadequate because as we begin to identify opportunities to make the regimen more safe, optimal, synchronized, cost effective, it's important that we close on the back end of the physicians. And so we spend a lot of time thinking about how we can make our way into the workflow of the physician office so they can adopt our recommendations. And that's it.
So before Dr. Yuri starts, he's going to take a world view of this medication adherence problem, which I've never personally heard, so I'm really looking forward to this. However, this is going to require some refueling on everybody's part, right? So we're all going to get up, grab some food, because there's lots of food out there, right? And only if you have a full plate, then you're allowed to get or at least 1 hour. Let's go. Please have a seat. So please meet Dr. Yuri Quintana.
Thank you for inviting me. And, I am with the Division of Clinical Informatics, which is an academic division of Beth Medical Center. And we do research and evaluation of clinical informatics systems, not only in the United States, but we've been working in the Middle East, and we're expanding into Asia Pacific region. And I just joined. Can you hear me back there? If you can't, please just raise your hand and I'll speak up. And so my role is to sort of understand global trends and help evaluate systems globally and understand the differences that there are both in implementation and outcomes around the world. My own background is in engineering, and I've been working in e-health for 20 years. And what I want to show you today is just some global trends And just a few examples of things that are working and not working. It's a huge field, so I'm just going to highlight just a few key facts just to stimulate thought. So I'm going to cover some global health trends that are happening, which I think are relevant that when you're looking at these systems, you need to sort of also understand the global context of things that are happening and where are the opportunities for expansion. And so one of the trends that's happening worldwide is just a very fast-growing aging population. And that aging population is expected to triple by 2050. And if you look at different large areas where this is growing, and if you look at China alone, they're going to see a rapid growth of the percentage of people that are over 65. Getting up to a growth of 12% per year. And right now, there's 120 million people in China and a growing mobile population. So as you think of systems and companies that you're developing here, there are enormous markets that are growing in Asia and other areas. And so it would make sense if you want to grow your business to start thinking about how you would take your systems here and deploy them in other countries. And then the question is, what are the differences that you're going to have to do to your product to make sure that they're usable and effective and can integrate into those other healthcare environments? Spending is not only in healthcare is not only a problem in the United States, but it's globally, and it's going to expect to continue over the next 5 years to continue to grow globally. So at least a 5% increase worldwide, and in certain parts of the world there are double-digit growth in terms of expenditures. So that's partly driven by growing coverage of health insurance and also demand by an aging population. One of the enormous challenges that there is just that there's a limited number of healthcare providers, and that limit is worldwide as well. So if you look at the total number of physicians, the number that are being graduated from different universities, it's not going to meet the global demand, and it's also a problem for nursing. And so if you look at this chart, for example, it shows that the growth of physicians is going to be growing slowly compared to the global population that's growing much faster. There's going to be a shortage, for example, in Europe of over 200,000 physicians. In places like Africa, the problem is even worse because you have very few universities. People in those countries try to lead towards higher economic opportunities elsewhere. And so with a very strained system with not enough healthcare providers, then we have to start thinking, can technology be useful ways to deliver healthcare and be able to follow up with patients? And that's where mobile technologies and other things become a very large opportunity. And then there's an emerging opportunity because of technology, because of mobile health, cloud technology, and wearable technologies, which allows us to create new ways of delivering care. And the challenge then is, how do you integrate all those technologies such that you integrate with physicians, payers, patients, government agencies in a way that fits into the ecosystem of that healthcare. And if you look at the growth that we've seen at this point in technology, there's been a lot of growth in mobile health, but most of that has been in wellness. If you look at a small number in there in terms of medication adherence, only 1.7% of the mobile apps are in medication adherence. And so I think as people look towards saving costs, then they're going to look to applications such as mobile medication adherence as an opportunity. So I think right now the buzz is on wellness, but I think the real financial and economic growth will be on applications such as medication adherence. And if you look worldwide at some of the problems that there are in medication adherence, the problem is very similar worldwide. So in terms of the number of patients that aren't following their medication, it's not only true in the United States, but it's true in Europe and in Asia. And here, I won't go through all of these numbers, but for example, in the US, 50% of the 3.2 billion prescriptions that are dispensed are not taken as prescribed. If you look at Europe, 50% of the patients do not take their medications properly. France, which has done some in-depth studies and evaluation, found that 20% of the patients don't even buy the medications that are prescribed. So this is a global problem. So there's a need for the kinds of solutions that you're developing worldwide. So the question is, how do you then take some of those innovations and apply them worldwide? Mobile is an interesting opportunity because we're starting to see a very fast growth of adoption rates of people buying it. And one of the questions was seniors going to get onto the smartphone wagon? And so a lot of them are increasingly buying smartphone technology. But the question, are they using it for things such as medication adherence? And I'll show you in a second some studies on mHealth for seniors. So there is a growth of the technology. Seniors are having them. And there's a lot of expectation. You'll see lots of quotes towards the last week here of the potential to save it. But what a lot of healthcare systems and hospitals are going to want to see is reliable, independent evaluations that show exactly what the cost savings are. And I think if you're a company and you're just tossing numbers of your own product, if you don't have independently verified numbers, I think it's going to be a lot harder for you to sort of get into the larger systems because people want, given that there's so many growing number of vendors, they want to know which one has actually been independently verified. So I think this is an opportunity for companies to start thinking of partnering with universities and other groups to start getting more objective evaluations, which will give more credibility to the space. And the more evaluations there are that are reliable, then I think the faster this sector will grow. But that's hindering right now a lot of the adoption because people are asking for where is the solid data. There's a growing body of literature in evaluation of this, but still I think it's still quite preliminary. And I'm going to point out one study which pinpoints a major problem, I think, with a lot of these systems, and that's in terms of the usability. So in this particular paper, it showed 5 different major evaluation systems, and they evaluated with different users. And when they asked them in terms of the usability, most of the reaction from people were on the negative side in terms of frustration on using it, accessing it, and a lot of the things were just basic mistakes in design in terms of navigation. People didn't know how to move forward. The systems had too many things on their screen. People got confused and a lot of frustration. And so I think there's a tendency for us to want to put all these ideas into our solutions and clutter the solution. And I think it tends to create complex solutions that people don't use. So a lot of the papers that are coming out in the mobile mHealth space, including the ones in medication adherence, really advocate towards simpler user interface design with linear navigation, about having the most important features to be very easy to use without any training. And in particular, one thing that is not being done a lot is in terms of designing for seniors, in terms of font size, color, navigation. So there is a body of literature out there, but there's a disconnect between what the academic world is producing and what the industry is doing and not reading the other. So I think both sides need to sort of find a place to sort of meet and communicate. And there's a need to sort of do better requirements analysis that creates personas, use cases, different types of wireframing, usability testing, long before you actually ship. And there's a rush to sort of get the product out there, but if you rush it out and people can't actually use it, you won't actually solve the problem. So there are known methodologies for doing this, and so people need to put more effort in the upfront design instead of just rushing out the door. One of the things that hasn't been thought too clearly is really the care communication, because medication adherence, especially with seniors, is really in the context of family care. So if you've got a senior or an elder who's 80 and 90, and we've got a project right now where we've developed a platform to communicate with seniors, and it's also going to have task coordination and medication. Typically, as seniors get older, 80s and 90s, the family gets involved in helping provide that care. And so then the question is, how do you bring the family to be able to access that information of whether they're taking their medications and create customized solutions? And when you start bringing in the family and creating these ecosystems and online environments, then you need to understand the culture. So for example, if you're going to deploy in Asia, you need to understand how families interact there if you're going to deploy in the Middle East. And so I think these design considerations need to be placed. Another aspect that's overlooked, and it's been mentioned earlier, is health literacy, which is people's non-ability to read, but actually comprehend what you're actually saying. So if you're saying, do not take with food and medicine, take twice a day, 3 times a week, some of these explanations are very confusing and difficult. And so there are methodologies to test health literacy, and often that's not done with these products. And then these solutions also need to be deeply integrated with the healthcare system, because if you just have a mobile app that works on its own, it won't be able, the healthcare system won't be able to see, communicate with you what medications are being dispensed. You won't be able to do the analytics. You won't be able to do the evaluation on the return on investment. And so what do we need to do? We need to have better models to evaluate these systems. We need to agree on what are some of the metrics. What does it mean to be adherent? And it could be different depending on disease. It could be different depending on the healthcare system. We need to have these evaluations more publicly available, independently done, to help grow the area. And we need to understand how to modify these solutions to fit into different healthcare systems that fits into the business models and the cultural platform of that region.
So this is sort of the best part where we get to hear from you. And then the whole, remember this session was labeled leveraging innovation, right, in medication adherence. So I think a good way to do this is we would like for you to share with us, ask questions also. But if you have a view, share that as well, all right? But we would just ask that, you know, keep that short, not like people here just went on and on talking, right? And then we'll get into a discussion. Okay? And we do have some additional questions that people have asked that we'll bring up over here. So please start. Who would like to? And then do introduce yourself, please.
Yeah, sure. My name is Bill Ferentz. I'm an entrepreneur in Boston, and I've got a question for Kevin. I appreciate the high-touch model you have, because I've got like a 90-year-old grandmother, and I can imagine she takes a lot of medicine, and that somebody in her home giving her that human element really would change her behavior. How, logistically speaking, do you manage that whole process of getting a person into another person's home? Because that's really, really tough.
It's really hard.
Yeah.
It's really hard. I guess I know what it does in adherence. Well, look, we do medication management. We think of medication adherence as something what we do.
Could you speak up a little?
Yes, certainly. Oh my gosh, Carol. She's making me stand up and speak up. So we do medication. First of all, I was just saying that it's logistically a very difficult thing to do, quite honestly. Depends what the program is. If it's a transitions program where we're trying to prevent 30-day readmissions, it's not easy to do, because right now there are a group of patients who were discharged this afternoon that we'll learn about tomorrow morning, and we want to be within their home within 48 hours. So that's hard, right?
Does the doctor, you're asking how is it permissioned?
How is it what?
Is your question, how is it permissioned? Why do they
No, well,
Okay.
I'm more logistically speaking.
Okay.
How do you find the right person in the right area?
Yeah, so
And they have to drive their car there. I mean, it's an
it's
effort.
logistically
Yeah,
very
operational.
difficult to do. And we were driving up, so I know something about Bill. We were riding up together in the elevator, and you're working on a platform. May I share what you're doing?
Yeah, of course.
You're working on a platform to leverage telemedicine, if I understand it correctly, in the behavioral health community. And I think that we've thought about that too, because it makes a lot of sense. But even that isn't perfect, whether it's teledoc
Well, it wouldn't work for my 90-year-old grandmother, right?
It would not work?
No, but
right.
She doesn't have a computer.
So, right. But she could, right?
Yeah, she wouldn't.
Could. I mean, there's a lot of innovative stuff that's happening, but sometimes it's really just being with that person and seeing what's happening. It's the gestalt that happens when you walk into the home and you see that everything is in disarray or not. That really gives you a sense of what's happening in the home and what the patient might need. So, Bill, logistically, very difficult to transition a program. Easier in other programs where we know in advance who the patients are and we can do a certain amount of concentration of the patients so that the pharmacist can see a number of them in the same day. Does that answer your question? Or?
Yeah.
I was getting on to something else, but I forgot because Carol made it.
No, thank you. I think that always just make sure that Bill is there with his grandmother. That's it. Okay,
Yeah.
other questions, please. Yes.
It's easy to generate reports and see that this works for this person. So these are personalized reports, and I am guessing you give these reports to doctors or insurance companies, either ways. And then how do you build relationships with the patient? So you build reports and get a plan that works, and then you build relationships. But how do you work together to make sure that something works and it is adhered, right?
Let me stand up.
I was good because you know that.
I know. No, but that's a great question. So we would work together kind of like peanut butter and jelly. So, and actually the third, the bread for this sandwich, if I stay with the same metaphor, would be like a health plan that has membership and data. You always have to have data. And so what we do after we do the analytics is, at the end of the day, what he needs is a list of people and names and whatever else you may have better information on, address, name, rank, serial number, than come out of the analytics. But at the end of the day, I deliver reports and all that stuff, but what I really do is I deliver a list, electronically delivered, that goes into a workflow. And so those lists, and there may be 3 or 4 different interventions that you're running. One is transition of care, going into the home, another's telephonic, another may be messaging on some mobile device, but they're different solutions. And so the list is people matched with solution that then just kind of, whether it's monthly, whether it's weekly, whatever the data modalities, can handle, and the interventions need. So that's what we do. Does that make sense?
Yes.
Vipul, you're welcome to join us here, please.
Oh, that's fine.
Yeah, because you do have some solutions.
Oh, okay.
All right. I don't know who raised their hands first, but we should let the organizer be.
So I just want to ask you, now you talked about identifying high-risk patients.
Right.
Now, when it comes to software, garbage in, garbage out.
Right.
So if you don't have the good data, especially non-adherent folks are, from a lower socioeconomic status, and they're not reporting data back.
Right.
So how do you identify these patient population? And this is the biggest, the riskiest patient population.
Right. And I can confirm, at least what we've seen, is that it is the riskiest. And in particular, when we calculate the value per person, and I can graph that by income, and it drops like that. So this is high income, this is low. It's sad, actually. Now, how we do that? It is garbage in, garbage out. If there is a health plan, we need the people that we work with to have their data under governance, and I think that's starting to happen more and more. We don't ask for perfect data, right? So what we do is we can work with whatever you've got. What we really need are claims. Medical claims, pharmacy claims. I can actually predict adverse events with just pharmacy claims. As it turns out, it's kind of cool. But this particular client had some data from a consumer database that allowed me to pull in socioeconomic proxies, which was very cool. And I pulled in some public health stuff from the Robert Wood Johnson County Health Rankings, which was also very cool. And they actually show up in the modeling process, and it just validates what we all know about socioeconomic status. But what I need is people to have data that is the stuff that they should be getting under control right now. And then as interventions are run, what we do is we'll take data coming from the interventions. Every single one of those check boxes that you saw as a way of instrumenting the intervention. When you go out and ask people what's going on, you want to capture that in a way that can be analyzed and have a controlled vocabulary around it and all of that. So then that can also come into some of what we do.
I would like to challenge that notion. Even if for those people there is data, but we have not tapped it in. I mean, those guys will go and buy food from somewhere. They'll buy magazines from somewhere. So there is this whole set of non-traditional data around consumer, buying, consumer. They will browse the web somewhere. They'll go to the library and click somewhere. We haven't tapped into those data sources. Now, admittedly, that's not pure clinical data. That's not claims data. But we can learn a lot from it. So go ahead, yeah.
Well, I mean, pharmacy claims are the fastest and they're easy and they don't discriminate across, income level or anything. You fill a medication at CVS, Rite Aid, you name the pharmacy, and there's a claim. That you can get that daily, I think. Am I right? I'm looking at data now, right? Those are the type of things. Medical claims take longer,
right?
Yeah, but pharmacy claims are. You have to get your medication from somewhere.
But isn't part of the problem that the claim the pharmacy doesn't communicate with the physician or the main patient-centered database? Like
they won't communicate with the physician necessarily, but they will with the payer.
Right.
Actually, I want to pick up on that point. He's raising a very important point. In all our discussions so far, we've completely avoided the provider, even the providers themselves. That's a challenge, and I understand why. Because
what about my whole clue?
I'm just kidding. Just making controversial. The point here is that a key place where the medication adherence plays out is the care delivery workflow. And what I meant is no one talked about the care delivery workflow, how it interacts with the care management workflow. Yes, there is a reason why the two are separate today, because the value proposition of bringing them in has not been discovered by the market so far. And that value proposition will happen when the risk gets truly and well transferred from the payer to the provider. We are in the middle of a long journey. It will take maybe 10, 20 years before that happens. And that's where I think that anything which accelerates the transfer of risk and makes the provider comfortable on taking the risk will actually create the real innovation in healthcare. Right now, everyone is playing around with the payers because payers have all the money, right? So that makes sense. But the real problem, the real collaboration around medication adherence is three-way: the provider, the care coordinator, and the patient. It has to be a three-way. So I kind of agree with the point the gentleman was.
So let me add to that controversy.
Yeah.
Okay. So when we started our product development and so on, we had prototypes, we had working products. We went to many physicians, some of them were my friends. They happily took the meeting. Great, everything's good, wonderful. I said, what kind of data are you interested in? I go, what do you mean? I go, don't you want to know about your patient's adherence? He goes, what am I going to do about it? Right? I mean,
well, they assume 100% adherence.
Yeah, well, yeah, of course they are.
See, let me bring you a big secret. When you give a patient Lasix, which is a diuretic, and you put them on 20 milligrams, when they come in and they are having difficulty breathing and their legs are fat, you just assume they need more Lasix. It never occurs to you that they didn't take the medication. It's funny because it's true, right?
No, you're right. Yeah. So
they don't think there's an adherence problem.
So since then, I don't even go near any of my physician friends or anything. It's like, okay, they don't have time, energy, or incentive. But someday they will. Okay, someone, please go ahead. Sorry.
Yeah, can I go ahead?
Yes,
so the ROIs look pretty compelling, but we all know with healthcare, the reimbursements, the incentives, as you sort of covered, I mean, they're a little bit skewed. So just wondered sort of where the payers are now in terms of sort of what's working, what's not working. Because I mean, if you look at this ROI, you'd say, wow, everyone should be doing this. But the reality is, I'm sure lots of folks, very few people are doing it.
Yuri, do you have any thoughts on that?
Well, I think part of the problem we have here in the U.S. is our healthcare. Part of the problem we have here is that our healthcare system is so fragmented that it's hard to see long-term ROI. So, for example, employees switch companies, more frequently now, and consequently they change health insurance plans. And so if you want sort of for chronic disease management, diabetes and even cancer is now very much a chronic disease because there's more survivors and more survival. To sort of find a business model that sort of transcends multiple stakeholders is difficult. Now there are places like, for example, in Barcelona, they have in Spain, for example, and especially in Barcelona, they have a lot of integrated, a common medical record system across the entire county. All the pharmacies are online. There's a high degree of mobile phones there. And there's a mobile health center that's been set up to do evaluations. So some of the things that, innovations that we're trying to do here could actually be piloted and evaluated a lot faster in some of these other centers which have more integrated healthcare systems and more e-health than we do here. We have a lot of e-health here in Boston, but it's fragmented.
But I'm sorry, I just want to get to Chris's question again. Do we have actual payers, health plans, who are paying for our services? Was that your question?
Really. Was it working now, basically?
Yeah.
Because it seems like a really compelling ROI.
Yeah, we made a great case, and then people should be lining up for our services, right?
Yeah.
Right. I think.
I haven't seen one for a long time. Please.
So I go out, and we don't actually provide interventions, all right? And there's a really important reason for that. It's a fundamentally different set of skills, deeply important, but they're very different than what we do. It's also important that we remain agnostic. Our job is to help. Like if I'm counting the votes, you don't want me running for election because I always win. How'd that work out? Having said that, so when we go out, and we've been out talking with payers for a while, it's interesting. The conversation is changing, and there are some payers. You've all heard that the future's here is just not evenly distributed. Well, same is true. Some of these guys are a little behind the curve, and they're just frightened to death. They don't know quite what to do. They were really upset when I said we don't do the interventions, right? But more and more, they need an ROI. They know that they're doing some stuff today. They know some of it works. They know some of it doesn't, and they want to sort that out. And they want to try new stuff. I've never seen the conversations shift from that kind of fear factor to okay, I think we're about ready to start. And so, and they're literally starting to shift in terms of used to be stars. Everybody had stars in their eyes, and you couldn't get them to stop talking about stars. Now they're starting to go, yeah, stars, I get it. Okay, but I'm interested in knowing where I can have more value than the bonus I'm going to get from CMS, right? So they want that and then some. And so anybody who is putting together an innovation to improve adherence, your day's coming. Your day's coming, and it's going to, I think you're going to start to see it next year, and it's going to accelerate after that. This is going to be a big deal.
So that's great. It's a very helpful conversation. So I'd love to hear from you guys that have seen some traction. What kind of advice could you have kind of tactically for people that are earlier in their product cycle, that are trying to get something off the ground, trying to close their first pilot, trying to close their first deal with a payer, or with a provider group or an ACO, like some practical, tactical kind of advice that you could give?
In the medication adherence space.
Yeah.
If you don't mind. Yeah. Okay. So every time we went to these payers, they said, "Well, where's your data?" So we spent 2 years trying to do lots of pilots, got wonderful data. We went to them. Here's the data. It was a big order. They go, okay, well, we'll now can we triple the size of the pilot or quadruple the size? So the reason. So my advice on the tactical side with this is, it'll take a year to get an order from them. You not have to convince the upper management, but all down the chain. Because what we've found is, I've convinced the CMO is no problem. Great. He loves the product, he wants it now. Because why don't you go talk to my director of nursing or director of pre-admissions, whatever. She has no time, energy. She delegates someone, no time, energy, and it takes 6 months, 8 months to convince all the people in the chain. So to me, that's some of the problems that I'm seeing. It's just very hard to move, trying so many different programs. They're trying this adherence from this, and they're trying this wellness from this, and now they can't figure out are the ROIs really due to this or due to something else. So that's my tactical advice. Other people? Anybody?
I've got another practical.
Okay, tactical advice, please.
Well, there was just yesterday or maybe last week announced some grants from CMS. And so payers, they can be very slow moving. Pick something smaller. Pick a self-contained, large employer, school system, whatever, where I'm telling you, if you save these guys real money, it'll save them money today, but if you can show that you can sustain that in both their employed and retiree population, you'll have their valuation actuary coming in and reducing the size of their unfunded liability. And so that gives them a couple ways. So find somebody who is, big enough to matter, but small enough to get your arms around, and maybe go jointly apply for one of these grants. Or not, on the grant part, but they may be really interested, yeah.
Okay, sorry. So one thing I wanted to mention, do you want to talk about this topic or something like that?
No.
Okay, so Dr. Batten here has an emergency. His computer is diseased and it needs to be fixed by Apple.
Don't tell these guys.
No.
I set up an appointment with Apple, and anyway, I have to get out of here.
And of course, without his computer, you can't do anything these days. So he has to leave now to get to his appointment. And so if anybody has any questions for him, I'd like to prioritize those then. Okay? Right? You remember he's the one who talked about high touch, low touch, right? Please, go ahead.
So,
actually, no, I'm sorry. Okay. Yes.
Thank you. So, as one of the providers in the panel, you've seen both sides. You've been on the BI side, and you're also now a vendor. So, what I'm curious on is, as the world is now shifting from the provider world now taking on more risk, to your point, where do you see the opportunity for some of these solutions to now be picked up by the provider world? You guys are mostly talking about paying, talking to payers as opportunities, but I see in the world that I live in, a lot of providers are now looking at picking up new technologies and new solution sets. I'm just kind of curious.
All right, so I'll make a couple of comments about that. We couldn't get the doctors to do anything until we shared risk. Okay?
No, totally agree.
All right, so I'll kind of leave from there, meaning, before we were sharing risk, people didn't want to change anything.
Absolutely.
And then the Blue Cross Blue Shield AUC contracts happened, and we got a surplus, several surpluses across our network back, and that got everyone's attention. And what they found was not only did they earn more money as a result of their performance, but they had cash for practice redesign, which is something they never had before. So, and you've never even thought about doing. So, I don't mean to be rude when I say that. You just didn't think about doing it, right? But now all of a sudden you realize, wow, if we have
good pilots with some providers, and what they've been able to do is go and talk to providers and push some alerts, some basic alerts into their workflow. That's it. And so that's another way you can play this game a little bit. So just wanted to add a few ideas.
Chris, do you have a question just because?
Yeah, I was just.
I've got a call before 10 o'clock Central Time.
That's fine, you can go. I don't want to hold
Which
you
is 11.
That's fine.
No, go ahead.
I was going to ask about social media, and because you talked about high touch, low touch, and if you're seeing sort of social stuff start to come in and actually be useful.
Not anything that we're doing.
Okay.
You mean patients like me and that type of stuff, or what do you?
Well, yeah, but also just in terms of getting the whole family engaged around sort of patient engagement, and if that can help actually sort of drive adherence and so on and so forth.
We have not done that, and I've not seen a lot of it, so I really can't talk knowledgeably about it.
So we're going to let you go, but I do want to let you know that Dana is there from Dovetail, right? Raise your hand. So if you have any more questions regarding Dovetail, I'm sure you'll be around, right?
Yep.
Great.
Oh, yeah. I apologize.
Great, thank you very much.
Thank you very much.
Some other folks had questions please.
Carol, I was wondering that you don't do the recommendations, you don't have a vested interest in what they are. Are there certain ones that, I know you're personalizing it, which I think makes a great deal of sense. Are there certain ones that seem to be particularly effective? I mean, it always, for example, occurred to me to something as simple as blister packs by the month that you're getting a monthly monthly medications. But in the U.S. we get, the pill bottles, or just something like, or I get CVS once a month sends me a text reminder to fill, and I always know I have 6 pills left over, so I wasn't very adherent. But just something like that. Are you finding that a few interventions are particularly effective within the population that you're targeting?
Yeah, I think there are some. I think it's important to recognize that a lot of what we talk about interventions, are making an implicit assumption on what the barrier is. And a lot of times we think the barrier is memory. And it may not be a memory issue. It could be, talking with Gail earlier, it could be a synchronization issue. It's kind of like that joke, Stephen Wright, if you guys know him, he goes, 24-hour banking, who's got the time? I mean, some of these people spend all day, every day at the pharmacy. They must have, BFFs over there. And so that could be the issue, is just synchronizing these things. Or it could be cost, or it could be beliefs, or side effects, or whatever it is. And so what I want these folks to do is to capture what those barriers are. And then, in terms of with reminders, I think I have seen some of those be effective. The ones that I've seen be effective are the ones that allow me as the individual person to kind of tailor when I get them, what's going to be the most useful to me, as opposed to, so I want something that's the same all the time, but I want to pick the time. And I want to pick the way. So I've seen, as example, those be effective. On the high touch, I've seen the CMRs that Kevin was talking about be extremely effective, especially when they're coupled with an ongoing, kind of motivational interviewing-esque approach in the psychology of behavior change, helping people build new habits, right? And learn about the skills that they need, which aren't necessarily condition specific, but it could be around, do they know how to interpret symptoms? Do they know what is a natural expected side effect versus time to call the doctor? And so when you have, what I've seen is clinicians that understand the psychology of change, couple the clinical information with some motivational techniques, I've seen those be very effective.
Just as a follow-up, when you talk about the barriers, have you seen or have you worked with a good assessment tool to determine what those barriers are?
The only one that we've worked with so far in this kind of value-based work is the Marisky scale, which, and I don't think that that's really, I'd like something else. So, and there really
in my experience, I haven't seen anything out there. And sometimes, you talk about synchronization or you talk about memory, it may be something, where I've experienced, if someone has a mental health issue, you're not going to deal with the diabetes until you deal with the mental health piece. And so it's not just about med assessment, it's a comprehensive assessment that you really need to pull together.
Many dimensions of the problem.
So, but in terms of validated instruments on barriers, I haven't really seen anything.
So there's a question here, and then we're going to take a question from this table. You guys are awfully quiet. I don't know what you're saying. It scares me when, it's like, but please.
Yeah, so this might be a loose thought, but I'm just trying to think of how increasing transparency and more visibility possibly accelerates this problem. So from a consumer standpoint, so if I had a 90-year-old grandma, for instance, is there a platform where I can evaluate providers based on their dispensation rate, how they manage chronic conditions, looking at the Medicaid adherence? So for this provider, 60% is based on diabetes, working in meds. So I prefer my grandma to go to somebody with higher compliance, things of that nature. So do you think something like that could cause some urgency in the system in terms of disrupting that and creating a separate incentive? Is that something that exists or currently?
It is a nightmare. I've thought of it too. I think something like that would be so cool. I've not ever seen one, and yet it is the kind of thing that I would want. Everybody, you think about your mama or your papa, and you'd be all up in the, but I think it would be really useful to see.
And what are the barriers at this point? Is it just the black box of data?
It's just, it's a data issue. Right?
So the other way to look at it, they've tried incentivizing patients with free, 0 copay. If you do that, you take your medication in time, you pick it up. Did improve the adherence just by a little bit, but medical outcomes didn't make a difference. So it's a tough problem. Someone from this, please.
I know Yuri mentioned this, the fragmentation of services. I just had a comment and kind of question on the fragmentation of services, right? I know you mentioned in Spain it might be more of a transparent model. I was wondering sort of what you see as the forecast and the means to the US becoming maybe more cohesive. I know you mentioned maybe academia being more cohesive with service providers, or do you think, is it, in the next 10 years, do you think it'll be a somewhat positive forecast? Do you think it'll happen organically, or will it require
So
sort
I think
of?
we're going in that direction, in part because of the technology that allows us, everyone wants to start, not everyone, but a lot of people want to aggregate their data to do analytics to sort of reduce costs, and so there are lots of initiatives for that. There's also employers now, IBM and certain other large companies are starting to look at how to sort of work with all their different healthcare stakeholders to try to reduce costs and come up with interventions. And so they've got some initiatives with case managers to help reduce. So they see the cost of chronic disease, which is, so chronic disease trends are an epidemic globally, and it's costing the healthcare system more and more. It's costing industry a lot more. Something needs to be done. And so I think the pressure, economic pressure of the cost of chronic disease is going to force people to do it. And it might be certain, either large players that have a large incentive like GM and IBM to do it, or it'll be maybe smaller providers but that are more agile with technology who will be able to do it. And it's anyone's guess right now.
I do think an interesting angle is sort of the employer angle. We haven't talked a lot about that.
Yeah.
So the payers are there, obviously, they have a certain set of incentives, but employers are the ones who are actually paying the payers.
Right,
and
they
so
want to optimize their results.
They want to, absolutely, just like they do in business. It is a major expense and they need to manage that. Someone?
I was just going to
sorry. Go ahead.
say we used to call them the employers. I worked at Genentech for several years, a cancer company. And somewhat because sometimes adherence isn't always the least expensive. In chronic diseases, I think it is in cancer, asthma, COPD, type 2 diabetes, et cetera. But in some cancers, it's actually cheaper for the payer if you're not compliant. So employers are often a good way to go.
Sure. There was a question back there.
Yeah, I was wondering to what extent can you accommodate the diversity of kind of demographics or cultural backgrounds in terms of how you decide to recommend interventions or extract insights from the data that you have. I've worked with a population that believed fundamentally that insulin was causing their diabetes because, the cause and effect for them with people coming in, things like that can really, that's going to take a first order precedence over just memory or synchronization of your therapy. So.
Right. I think that the people that do the intervention design, those types of kind of the knowledge and beliefs, and that some of which are deeply culturally embedded, have to come into play. So I don't know.
Are you accommodating for that in your selection of the blue one?
I've not seen anybody. No, I'm not. So it's certainly not a direct field related to kind of race or ethnicity. But I've also never, what we're talking about, and so I would handle that very differently.
So it's interesting you mentioned that. So we did a pilot with patients who were mentally challenged. And what we found is that they really embraced something like this, the pill station, because it gave structure to their regimen. And then it allowed them, along with some caregiver on the side, to manage their medication. Of course, in some patients who were of schizophrenic background, we had to turn off the voice. And then, I'm sorry, I shouldn't laugh at that, but really, we had to do that, and that it worked for them. The chime was sufficient. you had a question.
I did. It has to do with who's on the other end of some of these devices, right? And I'm wondering, so my question is, where's the growth in care management, right? So I think the payers have had this capability for a while. Providers have looked at it skeptically. Patients have looked at the calls from the payers skeptically. And what I am seeing, by the way, my name is Scott Parley, I work for Twine Health, and I'm seeing some care management growth within the provider organizations, and it's an excellent place for activation to actually occur, right? So you've got the provider saying, hey, you probably should be working with this care manager, and you can trust us. We have this, we're Harvard Vanguard, or we're Beth Israel Deaconess, and we should get started. So I just wanted to ask, any of you guys, where do you see the, for me, I'm, sort of the business mind here, I'm thinking I'm going to chase the care managers, right? Where the growth in the care managers. So interested in your thoughts. Yeah.
I think today it's with payers, and I think tomorrow it's with integrated systems and practitioners and ACOs. And I think we're at the early start of those transitions. I think right now a lot of ACOs are just kind of putting a new coat of paint on the side of the building, and so they haven't really made the deep investments that they need to in terms of systems and integration and what it means to truly manage a population. So it's just early though, but that's where it's going to go. They have the trust, they have the brand, right? Care is local, now takes on brand new meaning. And I think payers...
All about a nurse coordinator. Very different viewpoint. So the shift is happening, but be careful of what you sell to whom. Right?
Good.
That's only, there's a little bit of a challenge there.
So folks, it's time for us to close. If anybody has last thoughts, very quick questions, comments, let's do it, 15 seconds at a time, and we'll finish in a few minutes. So please.
So I have a question for you, Yuri. So the reason I have this question is Harvard has a huge network in Boston, right? I mean, a huge presence. You have the business school, you have the law school, and you have so many hospitals. So if somebody wants to start a business, you can go to the law school. They have a team who will help you with intellectual property. And if you had a business competition, there are lots of people at the business school who will help you with your business plan. And all that is free, right? But on the other hand, you also have tons and tons of hospitals. And that means you have access to so many patients that I'll never have access to. And so how is the way for somebody like an entrepreneur to approach getting it that, and you have a huge alumni, all right? So how is the way for a new entrepreneur to approach so that they can conduct a pilot study with these patients, just getting access to these people and doing a pilot study?
So I'm fairly new here to the area. I arrived in July, but Harvard is a huge, complex network, and it's multiple organizations. So there is the Harvard Medical School, but there are 17 hospitals that are associated with Harvard Medical School. So it's not any one particular place. It's a very kind of fragmented area, and there are opportunities for some of these fragmentations to synergize. One place that I want to quickly mention, there is a Harvard Innovation Center that was set up for students. So one idea might be for you to partner with, say, a graduate student in business school, who then might have access to some of the other Harvard resources. So there are different opportunities for
tremendous resources locally, and I think those are some of the avenues, and probably we can talk more about that afterwards. Any other last minute comments, please?
I have one.
Okay.
A simple
I'm
one.
just choosing people who haven't spoken. We do want to hear more.
Just curious if the slides would be available to share.
If everyone is okay with that, I'm okay with sharing it with the group and possibly posting it on our website.
Sure, absolutely.
Okay, great. Thank
Good,
you.
we'll do that. Any other comments? Please.
So statistics that came up for chronic disease and cancer, and it said a high percentage of cancer patients are dealing with depression, which affects their medication. And so I think in order to successfully tackle this, I think we're going to need to have a more 360-degree view of the patient. So so that the social worker, the nurse, the doctor, all that data is accessible so that if somebody's not being adherent, whatever the social worker observes can be made available to the physician, can be made available. We're probably 10 or 20 years from that, but certain places like Kaiser and other places which have more integrated networks, Mayo and a few other, I think are places where you can also incubate some of these ideas. But mental health and chronic disease, I think now has to be viewed together because you can't solve one problem without dealing with the other.
So folks, with that, we should conclude our evening. It's, I think, really important for us to acknowledge the wonderful organizers. I know they work really hard. Satish, who put the panel together. Good job, Satish. Al and Mike. There have been people who've done a lot of work behind the scenes and in front here as well. And of course, our wonderful panelists. And thank you, everybody, for a wonderful evening. Thank you.